Hello, and welcome to our Behavior Health 911 event. I am Melissa Silva, the Executive Director of the Louisiana Mental Health Association. Thank you for joining us today for this important conversation. We are grateful to our community partners, especially the local governing entities that have worked with us to produce this event. LAMHA also appreciates Louisiana Department of Health, Office of Behavioral Health for sponsoring today's and 9 other events across the state. We also want to thank our panel for sharing their time, expertise, and their lived experience. Over the recent years, the Louisiana Mental Health Association has worked with our partners to identify critical issues in our local communities and our state. And in response, we offer these informative discussions on behavioral health that affect both our youth and adult populations. As our state continues to work to improve programs and services for those most in need, Louisiana Mental Health Association stands tall in our efforts to educate and advocate for those same individuals. Conversations like the one today are a small but a pivotal step towards breaking the stigma surrounding mental and behavioral health and seeking the help one may need. Before we start this discussion today, I would like to highlight a few of our spring events. Louisiana MHA will be bringing you our virtual public policy on March 2nd, 2023. This is to make it easier for those of you to attend across the state. Our 6th annual conference will be held on April 25th through 26th, 2023, and will feature live virtual sessions. Finally, our Behavioral Health Day at the Capitol will be held on May 4th, 2023. More information on all of the events will be forthcoming, but we ask that you save these dates on your calendars now. Today's panel has been pre-recorded so that we eliminate the risk of technical challenges. There will be a live Q&A after the presentations and the speakers will join us. Please put your questions in the chat. You can add them now, or you can wait till the live Q&A section. Following the event, you will receive evaluation. Please help us improve these events by completing that. Again, I want to thank you all for joining us today. I hope that you learned much from our panel of experts. Have a great day.
Welcome, everyone. I am Doug Efferson, Executive Director for the Northwest Louisiana Human Services District, and we are proud to partner with the Louisiana Mental Health Association to offer this training opportunity to clinicians throughout our service area. Now, before the fun begins, I want to take a couple of minutes to let you know who we are and what our service mission is. Now, the Northwest Louisiana Human Services District, long name, we are one of 10 state subsidized districts or authorities that cover the entire state of Louisiana. Our part is to provide safety net, mental health, addiction, and disability services, primarily to the Medicaid and uninsured clients in the Northwest Louisiana area. Now, this includes 9 parishes: Caddo, Bossier, Claiborne, Webster, Red River, Natchitoches, DeSoto, Bienville, and Sabine. That's quite a lot of territory. We do our best to take care of folks in that area. Now, our behavioral health clinics, the brick and mortar locations, are located in Shreveport, Natchitoches, Minden, and Manning. And for those interested in our disability services, that office is located in Bossier City. But the easiest thing to get more information on these locations and the services we provide is to check out our website at nlhsd.org or follow us on our Facebook page at NLHSD. Now, I want to thank you for your interest in this training, and I want to thank the Louisiana Mental Health Association for identifying such great speakers to cover this topic. Y'all enjoy.
Hi, everyone, and thank you so much for joining this important discussion. My name is Tatiana Gonzalez, and I'm the Advocacy and Education Manager for the Louisiana Mental Health Association. Today, we're going to take a look at Louisiana mental health screening data. This data was made possible by mental health America National. This data was recorded during July 2022 through September 2022. During this time, 7,250 screenings were conducted. This was an increase of 2,215 screeners from last quarter. Now let's dive in and take a look at what the data shows. As you can see in this map, these are the top 10 parishes that participants screened in. The first was Jefferson Parish, followed by East Baton Rouge, Orleans Parish, Other, Lafayette Parish, Ascension Parish, 7th was St. Tammany Parish, 8th is Caddo Parish, 9th was Calcasieu, and the 10th was Ouachita Parish. Please note that screeners self-identified with these parishes. Mental Health America did not determine the parishes that the screeners were in. This graph shows the top 3 mental health conditions that participants screened for. The first was severe depression, followed by ADHD likely, and the third was positive bipolar. The Louisiana Mental Health Association wanted to dive deeper and look at the demographics of our screeners. 60.57% of our screeners identified as white/non-Hispanic. Our second largest race of our screeners was Black and/or African Americans at 22.21%. On our right, you can see household income. According to our screenings, 27.59% reported having a household income of less than $20,000, and 50.09% reported having a household income of less than $40,000. We also wanted to see what gender was taking our screenings the most. As you can see here, 69.06% of our screenings were women, followed by 26.27% who were men, and 4.67% of our screenings identified as other. On our right, you can see what age group screened the highest. 61.01% of our screeners were 24 and under. This really highlights the need for mental health services in this age population. Moving on here, we wanted to ask our screeners if they had ever received any form of support or treatment for a mental health problem. Unfortunately, 54.01% of our screeners had never received any sort of treatment for their mental health problems. On our right, we also asked if they were currently receiving any treatment or support. 53.32% of our screeners said that they were not currently receiving any support for a mental health condition. Below, you can see that we asked if they had any form of health insurance. 84% of our screeners said that they did have some access to health insurance. We wanted to dive in deeper and see what special populations made up our screenings. As you can see here, students were the highest screeners at 2,322, followed by members of our LGBTQ community at 1,197, and our third highest special population were trauma survivors at 1,159. 4,678 people who took our online screening described themselves as either being a student, a member of our LGBTQ community, or a trauma survivor. We also wanted to ask if they had any form of general health condition. Oftentimes we know that mental health and physical health are overlapped. As you can see here, 337 screeners had arthritis or chronic pain. This was the most prominent health condition identified by our screeners, followed by reproductive health concerns like endometriosis at 287 screeners. Our last highest were screeners who had diabetes at 164. Lastly, I wanted to end by highlighting one of the Louisiana Mental Health Association's programs, the Fisher Project. The Fisher Project is a comprehensive suicide follow-up and recovery support service. It is a 6-month peer-to-peer case management program that is at no cost to the participant. During this time, screeners are Participants are screened for suicide risk, and it's an ongoing assessment. It's aimed to create safety planning and means restriction. It also offers transitional care and a warm handoff to either the treatment or community. If you're interested in learning more about this valuable program, please contact Fisher Project at louisianamha.org or give us a call at 225-960-6800. I hope that you enjoy the rest of our presentation today. Take care.
Hi, my name is Ann Catherine Seaman. I'm a licensed clinical social worker in Baton Rouge, Louisiana. I'm currently working in private practice where I focus on helping individuals work through and cope effectively with trauma. So today's presentation is on trauma and effective treatments for trauma. So what is trauma? According to SAMHSA, they've identified 3 E's of trauma. The 3 E's are events, experiences, and effects. So they're basically saying that there are 3 facets to trauma that influence how people experience and respond to it. So for events, so basically trauma involves an exposure to events and circumstances which may include actual or threatened physical or psychological danger. That can either be from the environment or the worries in our minds. The other important factor to consider is whether or not a trauma is a single occurrence trauma, or it's repeated incidents, or if it's ongoing trauma, such as if someone was living in a place that was hit by a natural disaster, where they were seeing the effects of the natural disaster on a daily basis, or in a situation like individuals living in the Ukraine, where there's ongoing war, military fighting, and they're living in that environment. The third part of events that SAMHSA has identified, I used a quote because I thought it just said it better than I could have. They indicate that individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally hurtful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Each individual is going to have a different response based on their personal history, their brain chemistry, their body chemistry, their social supports, their emotional regulation capabilities, their spiritual experiences. Everyone's going to experience it differently. It doesn't have to be just one thing. It could be a series of things. It also could be ongoing stress of coping effectively with some sort of mental health struggle, like they said, the worries in our minds. Or the next component of trauma that SAMHSA identifies is the experience itself. So individuals experience events differently. What is traumatic for one individual may or may not be traumatic for another. Second, how the event is experienced may be influenced by factors such as cultural beliefs, availability of social support, and their developmental stage. So someone who is an adult and maybe past the age of 25, where their prefrontal cortex is fully developed, they will have a different experience of a traumatic event than maybe a 5-year-old who doesn't have a fully developed prefrontal cortex, has limited ability to utilize coping skills, or has limited social support, depending on what is going on in their life. Plain way of describing trauma, it overwhelms our resources to cope, which are different from person to person. So any event that occurs that overwhelms an individual's resources to cope will be experienced as traumatic. As we all have different resources available to us that help us to cope, the trauma I could get in a car wreck with one of you and I could experience it as a trauma, whereas you may not, because you may have more social supports than I do. You may have maybe seen a therapist and learned important coping skills that help you to deal with the trauma. So again, it's always going to need to be assessed on an individual basis because each of our life experiences are so different. Last is effects. So the adverse effects may occur immediately, or the onset can be delayed. I've often seen clients where they're concerned about, like, why is this just bothering me now? Why didn't it bother me before? You know, that's trauma. Everybody experiences trauma differently. Some people are immediately bothered by it. Some of us have different sort of responses that are, you know, built into our brains for one reason or another. And the onset is delayed. Maybe the onset is delayed because at that point, you are seeing a therapist and you can pull things out a little bit at a time with a safe person and deal with it. So it's not going to look the same in any person. It's always pretty much going to look different in each individual who's dealing with a trauma. Second, effects of trauma can be short-term or long-term. So some individuals have short-term effects from the trauma, whereas maybe they'll just have nightmares for a few weeks, whereas other individuals can for years experience panic attacks, anxiety attacks, trouble sleeping, nightmares again. It just depends on each individual and how they've responded to the event. Number 3, adverse effects: decreased ability to effectively cope with stress, attachment struggles, problems with memory and concentration, difficulty with emotional and behavioral regulation. So those are things that we can sort of typically see in people who present with wanting to work through a trauma, whereas they may have been able to deal with a high level of stress in a high level job before. That has been compromised and it's just not there anymore. Attachment struggles: sometimes after we experience a trauma, it can be difficult to feel close to people again, because maybe the trauma involves some sort of betrayal or incident where we were a victim of violent crime, and then it's like, well, can I trust anybody anymore? Problems with memory and concentration: if your brain is consistently working to cope effectively with a way to store and encode that memory, and then all the intensity of emotion is just coming up. If your brain's working hard to push through all of that, it's going to be a challenge to store things in your mind and to be able to concentrate like you did before. And lastly, difficulty with emotional and behavioral regulation. I think all the ones that were listed before are sort of lead up to this or are part of this. Like maybe before we were able to utilize journaling, meditation, exercise to be able to cope effectively with emotions. Those things maybe don't work anymore, which in turn leads to, if we're having a high level of anxiety, it's going to be difficult. Our ability to behaviorally regulate will be different because we'll need to do different behaviors. So I'm thinking in terms of maybe someone who is diagnosed with obsessive compulsive disorder. If prior to a trauma, they had learned some good coping skills and were able to cope effectively with the symptoms of OCD, that may be compromised should they experience a trauma. So again, they may go back to doing some of the old behaviors that they experienced with the OCD diagnosis. Trauma in the brain. So I just wanted to give a picture or a description of what happens in the brain whenever a trauma occurs. So when a trauma is experienced, the brain stores information in what we call implicit memory. So implicit memory is stored in sensory-based fragments. So images, sounds, smells, tastes, auditory, and they're scattered all throughout the brain. Well, human beings need words and a meaningful narrative in order to store the information from a trauma, like to take it from implicit memory and put it into explicit memory. So that way it has a story that goes with it. We can give it a meaning that makes sense to us, and we can consolidate all of those little parts that are scattered everywhere and store them. So that way, whenever we think about the trauma, it feels like it's happening in the past and it's not still feeling like it's currently happening, which is often what you see people presenting to therapy with, is that they're still reliving the event. It feels like it's still occurring. The triggers come out of nowhere because it's stored all over the brain and they're not really sure. Driving by a certain venue could trigger, we just don't know. So we want effective trauma treatments that help to consolidate the memory and store it with adaptive narratives. So this is a quote from Julie Smith. She is a psychologist and she has a book called Why Has Nobody Told Me This Before? I'd also like to show a little clip of her speaking about trauma and what happens in trauma therapy.
Now imagine this is you, and these are all the bad things that happened to you. So each one represents a memory of traumatic experiences that you've been through. And as you go about your life, the things seems like it's overflowing. Memories just keep falling out when you don't want them to, emotionally overwhelming you, and you can't seem to focus on the rest of your life. So what can we do about it? Well, I'm a psychologist, and this is what happens in trauma therapy. First of all, a therapist would gear you up with all the skills that you need to manage just how painful those memories can be. And then you take one memory at a time, carefully open it up at your own pace, and allow you to process that memory. And then you can neatly fold it up. You do the same with the next one and the next one until what you're left with is a neat little pile of memories that fit neatly at the bottom, leaving you more capacity to focus on the life that you want to have today.
So next, I just wanted to give a brief description of effective treatments that are typically utilized for trauma. The first one is EMDR. EMDR was developed by Francine Shapiro in the 80s. EMDR stands for eye movement desensitization and reprocessing. So we utilize what's called a 3-pronged 8-phase approach, which incorporates bilateral stimulation. So either eye movements from side to side, tapping on opposite sides of the body, like on the thighs or the upper arms. And the bilateral stimulation helps clients be able to keep one foot in the past and one foot in the present. And we take that memory and we turn down the volume on the emotional impacts of it. Then we give it an adaptive, appropriate narrative so that way we can store it or encode it in a way that our minds know it's happening in the past and it's not currently happening. IFS is another treatment modality that is typically utilized. IFS stands for Internal Family Systems. And Internal Family Systems was developed by Richard Schwartz, I believe in the 90s. His theory is that whenever we experience trauma, it forces parts of us into unwanted roles. Our minds have, different parts of our minds have different jobs. So whether they're managers, protectors, firefighters, or exiles, or some of his typical parts of our internal landscape, he says we want to unburden them and give them a new job description. So this is a very current treatment modality that is being utilized. And I'm giving a very brief description of it, that it's way more complicated than what I'm saying here. Next is medication. We often see people who are learning to effectively cope with trauma utilize medication management. So typically it's SSRIs, SNRIs. Obviously there could be more than that depending on what the client is dealing with. Prazosin I listed because it's typically a medication that's utilized to help people not have nightmares. We've also seen data indicating how effective yoga is in helping people to cope effectively with trauma. The concepts of mindfulness and the increased awareness of bodily sensations could be part of the reason that it is so helpful for people to recover from trauma. Lastly, and there's some debate about this one, is trauma-focused cognitive processing therapy. So it's basically CBT, RABT, but it's trauma-focused. And so obviously this is a treatment modality most of us learned about in school, and we have a good sort of foundational knowledge of it. And we'd be able to expand on that to do it from a trauma-informed lens. But there is some debate about whether or not it's effective, or that maybe it takes a longer amount of time to have efficacy than the other things I mentioned, due to the way trauma is stored in the brain or lack thereof, and how, basically our thinking minds, our critical thinking when it comes to our emotions really shows up to do a job it may not be best suited for. So I would encourage anyone using trauma-focused cognitive processing therapy to maybe incorporate some of the other modalities listed here. In summary, we know that events, experiences, and effects are factors which may contribute to how individuals experience and respond to traumatic events. This is highly individualized, and providers need to take this into account to determine which treatment modality would be best suited for each client. Actively working with them to determine what would best meet their needs and what they're comfortable with, what feels right during the course of treatment will render the best therapeutic experience possible and facilitate greater progress. So thank you very much for having me here today. I hope this was informative and helpful.
My name is Nick Rutledge. I am the Director of Behavioral Health Services at Coastal Family Health Center. We are a federally qualified health center stationed in Biloxi, Mississippi. It is a pleasure to be here with you today. I'm a licensed clinical social worker and accidental trauma therapist, and I'm going to be speaking with you for a few minutes today about the notion and concept of trauma-informed care and how, as clinicians and providers, we are sort of in a place where we need to transition from trauma-informed to trauma-competent care, and we'll talk a little bit about what that means. I am working off the SAMHSA model. SAMHSA has a really great sort of library of resources when it comes to trauma-informed care. So if you would like to reference any of my information today, much of it can be found at the link provided. As a trauma therapist, I thought I would start off by talking a little bit about some of the things that I see in my clinical practice every day. I see a lot of chronic physical and emotional pain. I see a lot of fear. I see a lot of shame and guilt, a lot of regret, and a lot of grief and loss. This is sort of in combination with or on top of the symptoms of mental illness that people are already struggling with. And so I'm going to talk a little bit about how a trauma-competent approach is sensitive to the nuances of some of these issues. I'm not going to talk a whole lot about definitions. I do like to make a distinction between PTSD and complex PTSD. Complex PTSD is clinically a little newer as far as the literature and clinical practice goes. PTSD has historically been thought of as something that someone develops after experiencing an event. What is reality for most people is that many people have experienced multiple traumatic events that happened over an extended period of time, over different developmental stages of life. And so that affects the human experience in our five senses in unique and nuanced ways. Framing our understanding of a trauma-informed approach, it's very critically important. One of the most important takeaways from our time together today should be that human beings are members of the animal kingdom. And we are, as such, governed by principles that govern any animal. There are biological principles, there are evolutionary and social emotional principles. The primary goal of any species is survival. And I really, really want you all to remember that, because so much of what we see in the clients and patients that we work with is very much a survival response. When we're talking about complex PTSD, we can think of symptoms of complex PTSD and many other mental illnesses as just being healthy, adaptive coping mechanisms, things that have been evolutionarily designed to keep us safe. However, we are experiencing these symptoms in light of perceived threat related to painful past learning experiences. And as a result, these adaptations have become maladapted due to their overuse. And this results in impairment of functioning and activities of daily living. So you can think of symptoms of mental illness, you can think of complex PTSD as really a superb collection of survival skills that have been exercised a little too much as a result of a person's current and past experiences. People with complex PTSD are overly adapted. They are superbly fine-tuned to maintain safety. They are experts at detecting and interpreting cues of threat in the social environment and professional identifiers of affective, vocal, and somatosensory abnormalities in conversation. What does that even mean? Basically, people with complex PTSD are experts in detecting micro changes in facial expressions, body movements, and tone of voice. And so as a result of these highly adaptive safety functions, they are hyper-vigilant to everything going on in their environment and will sometimes over-interpret certain cues that other people might not necessarily do so. Talking about trauma-informed care, it's kind of become a buzzword for behavioral health professionals and the mental health field. I'd just like to provide this slide to talk briefly about how many different evidence-based trauma treatments there are. There are a lot of different methods, a lot of different models, a lot of different theories about what's going on with people, why they are the way they are, and how we help them. I take sort of a common denominator approach, and I think a trauma competent care approach is probably the best place to start. Now, all of these different techniques are phenomenal. If you're a therapist and you want to get trained in any of these methodologies, I highly recommend it. It's certainly an effective use of your time, and these experiences will provide you skills that allow you to help people better. But from a common denominator, active ingredients approach, I think that trauma-informed care, trauma competent care is more about understanding the survival mechanisms of the human animal, if you will, and applying some basic core components to the process. 6 very important principles of trauma-informed care. Excuse me. First and foremost, safety. People are instinctually seeking safety, and the safety that they are seeking is a direct result of the painful past learning experiences that I mentioned earlier. And even if those behaviors are maladaptive, if they're not functional, if they're causing impairment, if they're causing problems, that does not mean the person is not seeking safety. Even if they're defining safety in a way or manner that is different than how you or I might define safety. Trustworthiness and transparency. Trustworthiness and knowing what to expect when it comes to service providers is a critically important part of the relationship between a trauma survivor and a provider. Peer support is a critically important area. Collaboration and mutuality. Empowerment is such a huge thing with trauma survivors. Having voice, feeling like they have a choice, as well as cultural, historic, and gender considerations. So many times when people experience trauma, there is often what we would call a violation of the social contract, meaning that someone who was supposed to love, care for, provide for this individual, not only didn't do so, but probably also harmed them in some way. So there's a natural distrust of professionals, of service providers, of therapists, of doctors, et cetera. And so aside from safety, one of the most important things that we can help impart for an individual survivor is a sense of control and predictability. At the end of the day, when combined with a sense of safety, that's what really makes the therapeutic relationship effective. Finally, very quickly, I'm not going to go into these specific areas one by one, but these are all the different implementation domains that SAMHSA sort of identifies or delineates for particular intervention. And you can see this goes from the very top of the organization down to how they do the books, to how they monitor quality and conduct evaluation. Every single layer of an organization has an opportunity to exercise trauma competent care. It probably seems a little overwhelming, and it can be, because there are so many different areas in which trauma-informed policies and practices can be implemented and should be implemented. But it really kind of takes a village. It is a slow process of change, and it takes time. But this is a good demonstration of how trauma-informed care, trauma-competent care doesn't just apply to those of us who are providing a clinical service or doing psychotherapy or providing case management or peer support. Any organization that serves people with behavioral health needs and ergo trauma histories has an opportunity at every level of the organization to incorporate these types of principles into the work that they do every day. I'm not going to get into a great deal of detail. This slide is probably a little overwhelming, but this is a slide that I use to teach information about what happens in a person's body when they're experiencing a fight, flight, or freeze response, all the different things that happen, and how that specifically compromises our ability to function in a healthy way. So when we're activated, our sympathetic nervous system goes into overdrive, and we sort of lose the ability for rational thought, problem solving, planning, impulse control, emotional regulation, all those things that our patients and our clients struggle with every day. And so I think it's really important to understand trauma and complex PTSD as an actual traumatic brain injury, because even though you might not be able to see it on a CT or an MRI, it is absolutely affecting the neural architecture in a way that is compromising a person's ability to cope and a person's ability to function. And unfortunately, over time, as one part of the nervous system, sort of works like a muscle and gets stronger and stronger, the other part designed to balance it out kind of atrophies, and it gets weaker and weaker. And so the longer people go without help, the longer people go without treatment, the more impaired they become in their ability to manage themselves in a healthy, effective, and functional way. And so understanding and being really sensitive to the nuances of these experiences becomes a really critically part of trauma competent care. Finally, I just provided a handful of really great resources that I like to reference on a regular basis. If you have any questions or like additional information, here's a really great white paper from the University of Buffalo, a really great school of social work that does a lot of work in trauma-informed care. And you're always welcome to reach out to me with any questions you might have. I'm happy to be as helpful as I can.
All right, great afternoon or great day to everyone out there. My name is Dr. Jeremy L. Blunt, and welcome to Trauma-Informed Care, Understanding the Right Approach. Like I said, my name is Dr. Jeremy L. Blunt. They call me the Stitch Doc. I am a therapist and a life coach. I specialize in crisis prevention intervention. To begin today, I want to remind you of the cognitive behavioral model and understanding thought process, and how things begin with, first off, the thought in your mind of what's going on, of what happened, and how that connects to the situation that happens, and how it connects with your emotions, and therefore goes along with your behavior. So here's a kind of little outline of, and this comes from the Substance Abuse and Mental Health Services Administration, SAMHSA, as many of you all are familiar, and they have what's called the 4 R's. One is to realize the wide range of impact of trauma and understanding the potential paths for recovery. And then there's recognize signs and symptoms of trauma in individuals, families, and the staff and the people that it affects. And then there's respond by fully integrating knowledge of trauma into policies, procedures, and practices of how you go about doing things. And then we'll close out today talking about resist, which is we want to resist the re-traumatization of individuals, families, those that are caring for them, all those that are involved. So that's kind of the pathway that we're going to talk about today. But to get started, we kind of first got to have a deeper and a better understanding of this thing called trauma. People who may have experienced trauma are 2 times more likely to smoke tobacco. You know, they're 3 times more likely to have a serious job problems, you know, to experience depression, to use anti-depression medication, you know, 3 times more likely to be absent from work. If you take it there and you pause for a minute, it really makes you think and helps you to wonder about some of the things that you are, you know, you hear about people experiencing and people just not being at work. Are they not at work just for the sake of not being at work? Or is it other things that are going on? You know, they're 4 times more likely to develop a sexually transmitted disease. You know, 4 times more likely to inject drugs. And then the biggest one is they're 15 times more likely to commit suicide. Folks, if you didn't realize that trauma is majorly impacted, then those statistics alone should have told you. So let's talk about how do we care for those people? How do we care? What is trauma-informed care? It's when you recognize that there is a traumatic event that is terrifying, overwhelming, and sometimes violating for people, just being able to recognize it and saying, okay, you know what, they need some attention. And being committed to not repeating these experiences in any way, but in a way to help to restore them to a place of safety, power, and of worth. All of us want to feel worthy. We want to feel worthy. We want to feel valued. That's what trauma-informed care is about. It's about approaching someone who have experienced trauma. Let's talk about trauma rates. You know, 2 in 3 children will experience trauma. According to SAMHSA in 2015, 2 in 3 children will experience a traumatic event by age 16. 2 in 3, that's pretty high. And then 70% of adults have experienced at least one traumatic trauma over the course of their lifetime. And, you know, every single adult, 70% of them, that's over half. Just about almost everybody that you meet have experienced it in some way, form, or fashion. Trauma disproportionately impacts, get this, people of color, women, and people who identify as the LGBTQ community. So here's what it's saying. It means it affects them more than it affects others. Maybe it's the social economic status, the people that they are around, the thought process because of previous experiences. Remember I told you how, this is why I mentioned about the experience itself and the effects of it. Because even though you may not be experiencing it presently, because of what you experienced before, it continues to be compounded. So then there's another statistic that 64% of people experience at least one adverse childhood experience during childhood. So this is what's called ACE, adverse childhood experience. let's talk about what ACE is. You know, there are 3 categories of ACE, and they are abuse, which is emotional, physical, or sexual abuse. Then there's neglect, physical or emotional, and there's household challenges, including substance abuse, mental illness, divorce, parental incarceration, or household violence. Now, to really understand ACE, number one, it's about a 9, there's a short version, there's a 9-question questionnaire. And the first survey was done through the Kaiser Permanente ACE study. And it was done from 1995 to 1997 in California for over about 17,000 people to get a sense of how their core experiences affected them immediately and how it affected them over time. Now, if you notice on the slide, there are those that are the core, first off, the household challenges. Those are the things that are inside of the tree. You know, if your parents were separated or divorced, if you had someone in the home that was incarcerated, someone that used drugs, someone that in the home you witnessed violence, all of those were one level of it. But then there are also community challenges. Those are the things that you see underneath the surface. You know, people's ability to get a job, people's the community that they grew up in, you know, drugs and alcohol and things of that, drugs being sold in the community. And then there's the third level of it is environmental, things that, you know, some of which they didn't have any control over, wildfires and smoke and you know, droughts, heat and cold droughts and you know, climate crisis, to everything from tornadoes or hurricanes. All of these things had an effect. According to that study, it showed that more ACE you experience, the more likely you were to experience poor health, poor mental health, and to experience death early. So ACE has a very large impact on people. So let's talk a little bit more about it. ACE, when you look at, okay, if I'm doing this not because of what I want to do, but because of what has affected me, then that means my behavior is a means of communication. You got to look at them and say, okay, can I look past what they're doing? Because I might not be able to explain why I'm doing what I'm doing, but there's a reason behind it. Seeing past the behavior to understand they're trying to communicate something. ACE people learn behavioral language that is response to their environment. In other words, their responses are almost, they're ingrained like reflexes. So interpreting this bad behavior as something to be punished rather than retrained, never going to be helpful. Why is this important? Because if you're going to relate to someone who has experienced trauma, you're going to care for them, you have to look past, okay, they may be crying right now, but I got to look past that. They may be angry right now, but I got to look past that. And understand that those that have experienced ACE, sometimes they're hypervigilant. That means the slightest little thing will set them off. You know, they may be scared, they may be afraid, they may have a lot of different things going on in their minds that, you know, it might make them hypersensitive to verbal and nonverbal cues. Sometimes, you know, you'll meet someone who's experienced trauma and simply you talking to them in what you feel is a normal voice, or you just call out their name, it may relate them to something else that they've experienced in their life, and they immediately gravitate toward that. And their response is a lot of times either to be aggressive or to shut down. So being able to pay attention to people enough to say, hey, there's something going on here past that immediate level that I need to give a certain level of attention to. So the effects of trauma are normal reactions to abnormal events. That's what it means in a long run. You know, polyvagal theory explains trauma like this. The response to trauma only makes sense in the light of evolution. In the light of what's going on, when you realize, okay, now I understand why they reacted that way. If I get past the behavior and understand, there's a quote Stephen Covey made famous in 7 Habits of Effective People. It's seek first to understand before being understood. If you understand why a person is acting the way that they are, now you're able to better relate to them, and they're better able to receive the help that you are offering them. Trauma can activate the autonomic nervous system and lead to a loss of resilience and remaining in a prolonged state of hyperarousal of the autonomic nervous system. So over a period of time, they can actually be almost like stuck in that phrase, in that mindset, in that way of thinking. So it's important to understand and to recognize that, hey, people experience this all the time. And just because they may have been like that over a period of time, doesn't mean that, hey, you should just dismiss them. So let's talk about this a little bit. It's important to understand that we all have vulnerabilities and how these vulnerabilities affect us. You know, vulnerability is not a sign of weakness and can be our greatest strength. Vulnerability is not winning or losing. It's having the courage to show up and be seen. You have no control over the outcome. Everyone is vulnerable, no matter how much they try to avoid it. This is important because in order to really provide the care for someone else, you have to be relatable. You have to have what I call empathy, to be able to say, hey, you know what, I'm gonna relate to where you are because that could have been me. There is no right or wrong way for them to feel. So making sure that they understand that. Don't ignore their feelings. It only slows recovery. So you want to encourage them. You know, avoid obsessively relying on traumatic events or things that have happened. You know, reestablish a routine with them. Hey, get them back on track. You know, encourage them to put major decisions on hold for a moment. Don't make huge life-altering decisions just in that moment. And then let them know, hey, when you're ready to talk, you be ready to listen. Don't push it. So how to support someone who have experienced trauma, you know, giving them these types of things, reciprocity, attribution, space, you know, allowing them to know that they understand choice. To close out today, I want to give you 5 quick tips about how to really help them. And these are what Substance Abuse and the Mental Health Agency recommends. And they are, number 1, safety. You know, focus on what you would do, to make the person you're servicing feel more safe. And not only taking care of them, but also making sure you check for your own sense of safety. Number 2, trustworthiness and transparency. Make decisions where the goal is transparency and building and maintaining trust. Let that be the guide for every decision that you make. Number 3, peer support. Support and mutual self-help. Identifying peers or what they call trauma survivors, those who have been through what they have been through, and connecting them together so that, hey, they can get the help that they need and be able, you know, it's something when you're talking to someone who's been through what you're going through. It makes the world a difference about how receptive you are to what they tell you. Number 4, collaboration and mutuality. You know, a lot of times we miss that we all have a part to do. You don't have to be a therapist to provide therapeutic assistance. So everyone has a part to do in what I call the healing process. It's important that all of your staff know their role. And if, you know, everyone knows that there is something that they can do, they can be a part of what is going on. And then number 5, empower. That means, number 1, empower by fostering an environment where the client feels they can succeed. 2, encourage clients to speak their truth, guide, advise, but allow them to lead. Allow them to know that they have the power and they are equipped with the power to choose. And in the event that, hey, they make the wrong choice, all right, how can we learn from this one to make a better choice next time? Don't just jump in and make the decisions for them. And the last one, and I can't stress this one enough, culture, historical, and gender issues. You know, there's so much right now about diversity and inclusion. Understand that everybody experiences things differently. And based off of their background, the things that they've gone through, the things that they've experienced, then guess what? Finding ways to be inclusive of who they are, where they are. And in order to do that, recognize that there are differences. 2, recognize your own bias. Truthfully, we all have some. Don't try to act like you don't. We all have some. And then practice inclusion and diversity to all that you serve. There is no one size fit all. To close out today, right before we go to questions, I like to pose this last statement. We are all broken. We are just broken differently. We are all broken. And it was Hemingway, a quote from Hemingway that said, we're all broken because that is how the light gets in. Think about that when it comes to trauma. That in order to provide that care, we have to remember that all of us, we're just broken a little bit different. At this time, I like to go to questions and answers. My contact information is on the screen as we move into the question and answer period.
Thank you guys so much for attending this session today. My name is Holly Jeffrey, and I am the founder of ACE Institute. And ACE Institute was founded about 2 years ago after I'd been working in the child welfare field for about 18 years. I worked for Child Protection Services for about 15 years, and then I've been training and consulting either with child advocacy centers or for ACE Institute for the past 6 years. I started ACE Institute after just experiencing just having this experience with these survivors of child abuse and neglect not thriving. I really felt like God called me into this profession 20 years ago. I did not want to be in this profession 20 years ago. I was just out of college looking for a job, and I got a phone call from Child Protection Services asking me to come and work for them. But I had never applied with Child Protection Services. I had never sent them an application. So for them to call me and offer me a job when I was praying for a job, let me know that this was something that God was leading me to do. And after 20 years of being in this, he put it on my heart, or 18 years of doing this, he put it on my heart that the survivors that I'd worked with all these years really struggle with thriving. We have the adverse childhood experiences study. We have all these outcomes from children leaving foster care where they are dying early, they're ending up in prison, they have substance abuse issues, they're homeless, they're being trafficked. And so he just really put it on my heart to educate professionals and communities on child abuse and neglect and the long-term impact child abuse and neglect has on these survivors, and to hopefully change the system as a whole. So one of the things I'm going to talk to you about today is how to do trauma-informed assessments with children in foster care or children who have been exposed to early childhood abuse and neglect. I currently have a contract with one of the states to do assessments on children in foster care. And as I'm doing these assessments on children in foster care, I'm reading the assessments of other professionals who have done previous assessments on these children. And so seeing some disturbing trends made me decide to focus on this topic with you guys today. So we're going to look at mental health assessments with children who have experienced early childhood neglect and trauma, about whether or not you are a safe person, and are we really looking at what that child's needs are in the moment? We have to look at our language. Are we using appropriate language with that child? What is our facial features like? Are we getting down on their level? Are we making sure that we're meeting all their needs? Are we meeting with them at a time during the day when they're usually hungry or taking a nap, or when they're sleepy, or when you know they were triggered after something? And so we really have to be mindful about that child and mindful about what that child's needs are. And have we set up our space and our personal demeanor in a way that's going to promote safety to that child? If they don't feel safe with us, then we're going to run into blocks when it comes to treating them in the therapy room. We have to look at the policies and procedures and the culture of our organization. There was one organization in another state that they realized that only 50% of their clients were coming to their first sessions. And they really wanted to improve that outcome. They wanted 100% of their clients attending their first sessions. And so what would happen is a client would get a referral to come to their mental health clinic. Only 50% of them would show up. So they took the trauma-informed information that they had and they said, okay, what do we know about trauma, and how can we implement these trauma-informed ideas to see if we can't improve this outcome and get 100% of our clients attending their first session. So one of the things that they did is they looked around their waiting room and they said, is this an inviting place? And so they realized that their waiting room and their building was not very inviting. So they went about changing the environment. They also knew that unknown equals unsafe. When you've got people who've been exposed to a lot of trauma, they are less likely to go into a new environment that they've never been in before. They're probably not going to call and make that referral themselves and make the appointment themselves, or maybe they will, but they never show up. And so what it is this is a new environment. This is a new person. This is a new therapist. This is a new building. And I would rather stay with the devils that I know than go try to experience new devils that I don't know. And so you're a new devil to them. And so what they decided was, knowing that new or unknown equals unsafe to a person who's experienced trauma, how do we make this environment known to them before they ever get here? So a couple of things that they implemented: they would have someone call the client from their office and say, you know, hey, my name is Holly. We got your referral. Thank you so much for choosing us as your mental health provider. We want to make this the best possible experience for you at all. Then they would get information about them, about, do you know where our office is? Do you know where to park? Have you ever been here before? And so they have a warm, inviting person calling to confirm the appointment. Then they follow up with an email. And in that email, they sent a picture of the building with a picture of the front door and a picture of the parking lot and a map from the parking lot to the front door, because this building happened to be in a city and the parking garage was across the street. So what they've done is they've created a familiar space now. Now this client has seen the building in a picture. It has seen the front door that it needs to go in, and it has seen where it needs to park, all through these pictures. Also in that email was a picture of the receptionist that this client would see when they first walked in the door. So now we have a face, we have a place, and that client can look at and be familiar with before they ever get to the building. And we've restructured the inside so that when they do get here, it's warm and it's inviting. What they saw by creating new policies and procedures in a safe space in their organization was that their numbers went up to at least 85% of first-time clients were coming to their first appointments. And so they took that data and were able to really hone in from there and try to make even more changes that were trauma informed to have more successful outcomes from clients. So it's about really becoming a safe space and a safe person for your clients. And they're going to want to come back to you after that. The next thing is making sure that in our assessments with these clients, we're doing a thorough job of assessing for adverse childhood experiences. There's the adverse childhood experiences questionnaire. It's a 10-question questionnaire that you can do with your clients. And I'm going to show you some other tools that you can use later on in the session. But I want to take a moment and I really want to talk about these adverse childhood experiences. Now, when we think about adverse childhood experiences, it is abuse, neglect, and household dysfunction in the home. That's the thing when we're talking about children and adverse childhood experiences. That specific study was looking at childhood experiences inside the home of that child. What does that mean? That means that these are chronic issues. This is not that one-time sexual abuse by Uncle Joe, behind Papa's house that one time years ago. This is the sexual abuse every night. This is the physical abuse every night. This is the household dysfunction that they're going home to every day, like domestic violence or an incarcerated parent or a mentally ill parent. They don't get away from this. And so what does living in that experience and being exposed to that experience do to that child's brain? To it. So we've got the adverse childhood experiences. We've got maternal depression and anxiety. We've got emotional and sexual abuse in the home, substance abuse in the home, physical abuse in the home, physical neglect in the home, domestic violence, substance abuse by the parents. And so as the kids are living in this every day, we're looking at the intensity. Was mom depressed, just a few times after she had the baby, or was she depressed and anxious and bipolar and schizophrenic for years and years and years and years and years? How long were my parents separated? Was this my whole life? How long was my parent incarcerated? The domestic violence, how intense was it? Was it just something that happened every once in a while, or were we in terror every day of our life? Was I physically abused just that one time, or was this like a weekly occurrence for me? So what we're seeing with these adverse childhood experiences, a lot of these were chronic. They happened all the time. The children couldn't get away from them. The intensity in some situations, I call them big T traumas, where it's this big, intense situation that happened frequently. Sometimes we have those little T traumas where it happened occasionally. They were kind of smaller things that were going on. Maybe like mom was depressed, a couple of times when I was growing up for different reasons. But we were always able to manage it. But when you're growing up in what I call the forest of bears, this is a situation where you've got a child who is living with the predator at all times. And the reason that I show this picture is because that kid who got that spanking that one time where it left bruises, that's considered an abused child. But so is that child who was living with that predator all the time, who was being preyed upon and tortured for years. Those two children are going to have extremely different behaviors and survival mechanisms and coping mechanisms, right? They're going to look different, and treatment for them is going to look different, or it should look different, because the way their brains have developed because of what they're being exposed to is going to be different. That child who was abused once and somebody listened and somebody intervened and changes were made, and now that child was safe and it never happened again, that child learned probably good coping skills, may have, a few minor behavioral issues, but overall seemed to cope very well with it because maybe some interventions were put in there. But this child that was exposed to domestic violence and physical abuse and terror for a long time, that child's going to have probably a lot more symptoms of PTSD. They're going to maybe have nightmares and night terrors. They're going to have a lot of different maladaptive coping skills. You're going to see this play out in school and their behavior at school. They may be diagnosed with learning disabilities at school, where instead of it really being a learning disability, they may be dissociating in school and not being able to pay attention because they're afraid of what's going to happen to them when they get home. And so I bring this up because this impacts that child's neurodevelopment. Their learning brain, when they are triggered, what we know when we're trauma informed is that when a child is triggered, when they feel like they are being threatened, when they feel like they're being in danger, their prefrontal cortex, which is their learning part of their brain up here, turns off. That's where they have the executive functioning. That's where they can weigh pros and cons. That's when they can have sound decision making. That part of their brain's not even fully developed until they're 21 or 22 years old. But so we have children who already don't have that part of their brain fully developed. And then when they feel unsafe, that whole part of their brain shuts down. And the part of their brain that does turn on is that limbic brain or that reptilian brain that is trying to help them survive this threat that's coming at them. And when they are in those parts of their brain, they're going to respond in a fight, flight, or freeze response. If we are not creating a safe environment for them to come in to do therapy in, and we are not fully assessing the trauma that they've been through, if they have been exposed chronically to this trauma for years and years and years, their brain is kind of hardwired. They're very hypervigilant, hypersensitive to threats in their environment. They're constantly scanning their environment for threats. Then they're getting triggered more often. They are staying in that limbic brain most of the time and not in their prefrontal cortex. Our strategies of working through their trauma a lot of times requires that they be in this prefrontal cortex. And if we jump into those trauma therapies too soon, before we've helped them regulate that limbic system, before we've helped them feel safe, they're not going to fully engage with us. They're not going to fully understand and be able to process that trauma. That's if we're even doing the full trauma assessments to begin with. I'm going to share with you an experience with a little boy that I had recently where there were no trauma assessments really done with him, and he was misdiagnosed, and therefore his treatment was not successful. So just to kind of go over with some of the issues with how trauma impacts the brain, this is a brain scan of a child who was in an orphanage in Romania, and you can tell the difference between that child and the child on the left, who was raised in a home where abuse and neglect was not common, was never reported. And so that child's brain is bigger. That child's brain has more going on. The child who was raised in that neglectful environment has a lot of black spaces and dark spaces. That means that there was poor brain development in those areas because those areas of the brain were not stimulated as much. But you see down there at the bottom that darker red, that's more of the brain stem, and that's more of that part of the brain for fight, flight, or freeze. And it's a lot more developed down there. It's more red down there. And so this child developed a lot more survival skills and a lot less executive functioning skills when it came to having to survive. And so that child is going to react more out of their survival brain than it is out of their executive functioning part of their brains. We also have to realize that these children have had no control over what happens to them. And so part of the behaviors that we're seeing is them attempting to have some type of control or mastery over what happened to them, or they're dysregulating because they have no control. You put them into new situations, or if they're in a transition between two grades or a transition between two teachers, or just they're transitioning between foster homes, you're going to see them act out more. One, because these are new situations and they don't like new. And two, because they don't have any control over what's happening to them. And we really need to be mindful of how difficult it is for children who are in foster care or are experiencing abuse and neglect, that they are in really terrible situations where they have no control, they have no voice. And when they do try to tell us, it comes out in these behaviors. And so it's like this person in this picture, they're screaming at you, trying to tell you what's happening to them, but they may not have the language to tell you. They may not have the words to tell you. They may not have the courage to tell you what has happened to them. So it's coming out in these behaviors. And if we are misreading the behaviors and mislabeling the behaviors, misdiagnosing the behaviors, then we're missing what's happening to these kids, and we're missing what it is that they're trying to tell us. Some of the behaviors that we might see from children who've experienced trauma, you have the fight, flight, or freeze response, and that's where they can be hypervigilant, they can shut down, they can dissociate, they can fight, they may be running or walking away. Sometimes they're running away and not coming back. Sometimes they're running away just to cool down. They can be very angry, they can be catatonic, they can be non-responsive. It's kind of going to be dependent on what area of the brain they're functioning out of at that point. You know, the brainstem area is where they're just going to be kind of catatonic and unresponsive, and they're just not going to engage at all. In the limbic part of the brain, that's where you might find the fight, flight, or fight response, where they are running from you or where they're fighting you, or you know, they may be freezing. When they're in their prefrontal cortex, when they feel safe, that's when they're going to be able to kind of weigh the pros and cons a little bit better, understand consequences a little bit better. And so really kind of being able to take the behaviors that you're seeing and associate it with the part of the brain that it's coming from will kind of help you assess that child better. You have emotional dysregulation. A lot of these kids just cannot regulate emotionally. They, you know, when they get angry, it's explosive anger. It may also be vindictive anger. When they get upset or sad or mad or fearful, it's going to come out in this overreaction, and they don't know how to control it. And so that's why it's important that we start with emotional dysregulation and build their skills in controlling their emotions before we ever try to jump into any kind of processing of the traumas themselves. And that's if we even get to the place where you've assessed the trauma. What I'm seeing, the trends that I'm seeing, is that we're just looking at the behaviors and we're not assessing whether or not it's related to trauma at all, or we're saying, oh, they were abused and neglected, then here's all the behaviors that we're seeing, and then we're, you know, labeling them with conduct disorder. But we're not really paying attention to the severity and intensity of the trauma that they went through. We're going to see manipulative behaviors out of them. You know, these are the behaviors that they had to learn to use to survive. So again, we have to be very careful with how we are working with these kids, that we're not blaming and shaming, because if we were to take them and put them into that environment where we've got the little boy and the wolf, he was having to do whatever it was he needed to survive, and we would never blame him or shame him for having to do that. And so sometimes when we take them out of context of what they're living in, as a system, we can blame them and shame them for the behaviors that they've had to adapt to in order to survive what they're living in. You may find sleep disturbances or physical pain or those somatic symptoms that they might be experiencing. They may also have dizziness and exhaustion and hypervigilance and nausea and racing thoughts. So it's really important to ask a lot of questions about their nighttime routines and how they sleep, and trouble with intrusive thoughts and things like that. Nightmares, night terrors, because these kids can experience a lot of those stomach pain. This slide, again, goes back to what I was talking about earlier. When you have an unknown situation, an unknown person, an unknown classroom, an unknown experience, if we're talking about kids in foster care where they don't know what's going to happen to them next, they don't know when they're going to see their siblings again, they don't know when they're going to see their family again, they don't know where they're going to go live tomorrow, that creates a lot of anxiety for them. So unknown equals danger. And when they feel threatened, when they feel like they're in danger, when they feel unsafe, that's when we're going to see a lot of these behaviors coming out. So it's important for us to ask about what's going on in your, like if we see an escalation in their behaviors, are we asking questions like what's going on that's different? And are we attributing the behavior to maybe some unknown situations that the child is facing? And as we're seeing that, we can hopefully start making plans for that child as we foresee transitions in the future, foresee changes in the future where they're going to enter a new grade, move to a new foster home, go into a new school, encounter new people. We might be able to start planning ahead to make those unknown situations more known. So I want to give you some tools that you can use. I do not see these tools being used by any of the professionals whose reports I'm reading right now. Now, I'm not practicing in Louisiana. I'm practicing in another state. And so when I read these reports, I do not see any of these tools being used. And that's what's so concerning for me. So this comes from the National Child Traumatic Stress Network. And so if you were to go to the National Child Traumatic Stress Network website, you should be able to go to screening tools, and you should be able to look up different types of screening tools for different things. This one is on complex trauma. These are for those children who have lived in the forest of bears or lived with the predators. Go back to that little boy in the wolf picture. He lives with the wolves all the time. He's not able to get away from them. And so that experience that abuse and that neglect and that trauma on a daily basis are likely going to have complex trauma. And so this tool right here gives you all of these different screening tools that you can use. Some of them assess attachment, some of them assess dysregulation, dissociation, anger, depression, sexual issues. Some of these children are sexually acting out. Lots of different ways that you can assess these children. And thinking about how you're going to proceed forward, if we're really going to say that we're trauma informed, then we really have to be trauma practicing. And to become trauma practicing, we have to actually do assessments for the trauma and not just asking, were you physically abused? Were you sexually abused? I was sexually abused, but I was sexually abused one time by an uncle. I did not live in this chronically my entire life. So how I respond to it and how my friend who lived with her stepfather who was sexually abusing her and then turned around and sexually exploited her by trafficking her, her experience is way different. Her issues now as a 33-year-old are way different than mine were. And so her treatment looks a lot different than mine does. So I highly encourage you, if you're going to be a trauma-informed mental health provider, you really have to start using some of these tools that really dig down deep into the trauma. You need to know when it happened, the intensity of it, the longevity of it, and really take into account how that impacted that child and now why we are seeing the behaviors that we're seeing in that child. And then go about making the appropriate decisions about the appropriate interventions that are going to help that child. Because if we get the diagnosis wrong in the beginning, then that's just going to set the stage for interventions that are not going to work. So going back to our presentation, I look forward to seeing you guys in live in a couple of months to answer your questions. In the meantime, this is my contact information. Feel free to get in contact with me. You can text me, you can email me, you can call me, and love to have a chat with you to see if I can help you in any way. And I hope you enjoy the rest of the trainings that are out there, and I'll see you soon. And thank you guys for attending today. If you need to get in touch with me, this is my contact information. You can call me or text me or email me. I'll be happy to get back in touch with you with any questions that you have.
All right. Thank y'all so much for this very informing presentation on trauma-informed care. I know here in Louisiana, we do face some of those risk factors that were mentioned by, I think, a lot of y'all, natural disasters, and that can cause a lot of people to experience trauma. I know we are reaching close to our time, so I want to be respectful. One of the questions that we have is, I know Dr. Blunt mentioned that some people might enter almost like a permanent state of hyperarousal in their nervous system. Once someone enters that state, is there a way to reverse it with therapy?
I don't believe that was mine that was that comment. To reverse it, first off, let me say it this way. Everything takes time. And the same way that it didn't happen overnight, it takes time to reverse it. So to short answer, yes, it can be reversed. It does require a special type of therapy and the understanding that it's not an overnight solve.
Mm-hmm. Yes, that's true. Like you said, and I like that Brene Brown quote that you used, that it takes vulnerability and constantly, it's a work in progress. It's not something that can just happen overnight or with one session or anything like that. I also just, one more question for really the whole panel is, if there is one key takeaway that you would like people who attended today's sessions to get from the webinar, what would it be? And this is for everyone.
I'll go first. I would say two takeaways, because I think it's something that all of us mentioned, and that's safety, right? They have to feel safe, and it has to do with how the brain interprets the environment. If they feel safe, then it's going to be a lot easier to get them emotionally regulated. It's going to be a lot easier to work with them in therapy. It's going to get that hypervigilance down. They're going to, and safety has to deal with trust. So you have to earn their trust so that they feel safe with you. The second thing that I would say is, making sure that you fully understand that trauma. When I read these assessments done by other professionals, in the intake, it'll say this child has been abused and is in foster care. And that's all they'll put in there. Well, abuse can be a kid who gets a spanking and has some bruises left, or it can be a kid who was tortured. And so if all you put, or if all you ask, have you been abused and neglected? And that's a checkbox that you check, yes, but you don't get kind of the insider details of what that entailed, you might not understand that the behaviors that you're seeing is coming from complex trauma, because complex trauma can look like ADHD. It can look like oppositional defiant disorder. It can look like bipolar disorder. And we can diagnose these children with the wrong disorders when it's really complex trauma and hypervigilance and anxiety and fear. And so what I'm seeing in these assessments are abuse, neglect, in foster care, and then it's listing all these negative behaviors, and then we're assigning a diagnosis, and we're not ever taking their trauma really into context and giving them a diagnosis. They're not being diagnosed with PTSD, so they're not getting trauma therapy. They're just getting cognitive behavioral therapy to help with behavior problems that they're having, and all the trauma is totally swept under the rug, and they're not getting better. So do thorough trauma assessments using good trauma tools that are out there, and then spend a lot of time building trust and safety with that client, and then you'll get a lot more progress with them.
Dr. Blunt, do you have any takeaways?
I will say, and I'm gonna group mine into one, the statement that I ended with, which is we are all broken. Hemingway coined that. That is how the light gets in, was his quote. But when I say we are all broken, it means everybody has experienced some form of trauma in their life. And so the takeaway is to remember that we all have something that we've gone through, and to utilize that to remember that we have to exercise empathy in what they've gone through, and understand that even though we might not call it trauma, we might not feel like it's as impactful, we're not the one that experienced it. And it's almost like crisis. If, you know, there's the definition of crisis depends on the person. So the definition of trauma depends on the person. If they feel like it was a traumatic experience for them, then it was a traumatic experience for them. And so I would lastly say to remember, it's not so much about the event that transpired, but it's really about the experience of it and the effects. Mm-hmm. A lot of times we focus so much on the event itself that we miss about the experience and the effects. How is it continuing to affect them today? I like, I believe her name is Holly. I don't want to mispronounce your name. I like what she said about safety, because that is how you establish that safety for everyone.
Mm-hmm. And Doug, do you have any last words for our panel today?
No, I just appreciate everybody. It's been a great group, and it looks like we had a lot of attendance. Hopefully everybody had at least one or two good takeaways, and let's put it to good work. Yes,
well, we appreciate you, Doug, and our partnership with Northwest Human Services District for putting on this presentation on trauma-informed care. I know it is a Friday, so we definitely had great attendance and really good conversations. For those who didn't get to watch it, we will be posting it online on Monday, and I'll be sharing the link with Doug to share with others. We'll also be sending out a survey on Monday to let us know how we're doing with these presentations. Again, thank y'all so much for watching today, and thank you, Doug, for our partnership. We really appreciate it.
You bet. Y'all have a good weekend.
Thank y'all. Merry Christmas, y'all.
Thank you, Holly and Dr. Blunt, too. Thank you.